This is Karen O'Hara. I'm the Director of Marketing and Communications at WorkCare. Thanks for joining us. This session is being recorded. During the webinar, you will be on mute. Please submit your questions using the Q&A function in Zoom. The webinar recording will be posted on our YouTube channel, and a transcript of the Q&A segment will be posted on our website within the next couple of days. We always share the links via chat during the session. We have a full hour scheduled for the webinar today to allow time for all of your questions. I'm going to turn it over to our speaker shortly, who's having a little technical difficulty getting his PowerPoint to load. I think that's the first time that's happened in over a year. So with your patience, he's on the call, but we can't see his PowerPoint yet. Our speaker is Anthony Harris, MD, MBA, MPH. Dr. Harris is board certified in occupational medicine. He's WorkCare's Chief Innovation Officer and Associate Medical Director for on-site clinical operations. He's also our lead clinician for WorkCare's COVID-19 response. So as soon as he's ready, I'm going to be turning it over to him. There might be a slight delay, so we appreciate your patience. We'll be right back with you.
All right, well, thank you, Karen, and hopefully everyone can hear me. Pleasure to be with you today. Sorry for the slight delay here. My PowerPoint shut down as I was trying to share it here on the screen. So thanks for your patience. And without further ado, we're going to jump into the presentation for today. If you haven't joined us before, thank you for joining us today. I am Anthony Harris, and we've been speaking and giving this presentation on a weekly basis for all of last year, right, since March, and recently transitioned into a monthly cadence for these discussions so that we can continue to bring you some thought leadership around COVID-19 and our approach to safety in the workplace as it pertains to dealing with this pandemic throughout the rest of this year and perhaps years beyond. Not to steal my own thunder for later in the talk here. To refresh you again, if you weren't with us this previous month, we changed the format up here a bit. We want to get more into presenting a business case for your institution, right, and for your workplace. And we're going to support that with some causal examination, diving deep into the why behind some of the trends we're going to discuss. And as we focus on these trends, we want to then step into some thought leadership as to how we can stay ahead of some of the trends that will likely play out throughout the 2021 pandemic as we have been experiencing it, prognosticating about the future of the pandemic. Then we'll really focus in on what trends are going to be forthtelling as to predicting a little bit of hopefully what we'll expect in the summer and the fall and inevitably the winter. And then finally, what are some of the messaging and the mechanics behind the suggestions that we want to bring forth from a clinical perspective, okay? And so with that in mind, we're going to jump into the business case for today, which is workplace vaccination tracking, all right? Last week we talked about, or last month rather, we talked about should we require vaccinations in the workplace. Obviously, that's ongoing in the debate from a public and private institution standpoint. But we want to talk about keeping the workforce safe throughout 2021, right? And trying to, at the same time, get back to a sense of normalcy. Another way to think about this is, well, how are we going to get towards or move towards a wind down of the processes we've been focused in on and have in place in regards to safety for our workforce specific to COVID-19, okay? So that's what we're going to focus in on today. Will there be a wind down, a return to normalcy anytime soon? What does that look like for us? And what are some of the trends that are going to affect our ability to return the workplace back to pre-COVID conditions in regards to our workers not masking or doing social distancing, et cetera, et cetera. Right. So with that being said, the first thing we need to focus in on, right, is how are we faring in the US in regards to cases, right? You've listened to the CDC talk about a focus on case rates, right? CDC reports on a daily basis, right? Total right now, as of today, cases, 32 million cases, right? And 102.3 cases on a 7-day rolling average per 100,000, with well over 500 million or 500,000, almost 600,000 deaths, right? 404 deaths newly reported as of today from yesterday, right? And so when we see these numbers and we look at the downward trend that we've been seeing for several weeks now of COVID-19 cases, we start to think about what is the threshold for returning the US back to normal, right? We can look at another publication from the CDC and looking at new cases and then a 7-day rolling average, 48,000 cases, 48,000 and a half cases on a 7-day rolling average as of May 3rd is where we were, right? So again, if we look at history of when the pandemic first began, March of last year, we are still far above those levels of the beginning of the pandemic. And recall, when we were talking about the social distancing and the restrictions that we put in place last year, it was during that period prior to escalation, right, that we had social distancing first introduced into communities, right? And so with that notion that we are still far above those numbers previously with social distancing in place, obviously we're looking for a threshold for returning the population in our workplace back to a sense of normalcy. Now, CDC has not come out with a threshold at this point. No one has really put a number. Johns Hopkins hasn't really put a number to it. And so we're going to try to look at trends to try to estimate when and if in 2021 we will hit a point or threshold that will return us back to normal. So we know the science behind the CDC recommendations that recently came out about outdoor mask guidance, right? Those individuals who are vaccinated no longer require wearing a mask, even if you're in the company of those who aren't vaccinated, provided the setting is a small gathering, right? So CDC has not put a threshold number to what denotes a small gathering. Rather, they refer to what is a large gathering or substantial gathering. So a concert, a venue in which, like a baseball game or a football game, in a venue in which people are in mass together gathering. Those scenarios, they still recommend those who have been vaccinated to wear a mask. And we're talking about this obviously because we want to get into the CDC's recommendations that start to give us a glimpse into normalcy, right? If you zero in on Chicago, what has happened just yesterday, the mayor and the governor of Illinois have reintroduced reintroduced efforts to reopen fully by July, right? The big Chicago Auto Show is now back in play. So we're seeing these trends of trying to reopen in those locations and geographics that have historically been more conservative, right? Obviously, those states, Florida, Texas, others that have reopened in regards to 100%, with still some in cases of wearing masks and others, obviously no mask scenarios. And we'll see this play out, and we've seen this play out along party lines, right? But now we're seeing, again, in those traditional conservative states, more guidance around reopening back to 100%. So will this continue, right? We know vaccinations are key to seeing the trend of reopening in these conservative locations. So let's dial into our vaccination efforts here in the US in particular. We see that a total of 146 almost 148, or excuse me, 147, almost 148 million individuals have received at least one dose, right? Representing 44% of the population. 106 million have received full vaccination, representing 32%. So we'll pause right there, right? Because this is representing the AstraZeneca vaccine that's not in play, right? These numbers do not represent AstraZeneca. These numbers do not represent other vaccines that have been in play across the pond. Only the vaccines approved by FDA, EUA, right? So we're talking Johnson & Johnson, even with that little pause that we saw weeks ago, we're talking Pfizer and we're talking Moderna, right? So again, these numbers represent only those three vaccines. And we know that only the individuals that have been by far and large vaccinated have been 18 or older. Only one of the vaccines are approved for 16 and older. So we're talking about a population of adults of 40% fully vaccinated at this point in time. So if you recall our herd immunity talks previously, we know that herd immunity for COVID-19 level of vaccinated individuals, and not just vaccinated, immune individuals, right? And in this case, immunity being primarily through vaccination in terms of longevity and robustness of immunity to SARS-CoV-2, the wild type, and the mutations or the variants that we've talked about. We know that the number to reach herd immunity is around 80%, right? So we are far afield from that number, and we're starting to see a downward trend over the last several weeks of those who are signing up for vaccination, right? So as we talk about then what's on the horizon that may help efforts, perhaps AstraZeneca is now being approved in Canada for children 12 to 15, all right? If we look at clinical studies, Pfizer, I mentioned AstraZeneca, I meant Pfizer is being approved, been approved for 12 to 15 in Canada. And what this gives us hope for, obviously, is what will play out in the US. If we dial into Canada specifically, Pfizer's study, as we look at age groups younger than 16, there are three groups, right, of children that the study has looked at. And these three groups will likely be approved for vaccination in stages. And so 12 to 15 is the first stage, the first age group of children that we'll see likely play out in the US. The US is expected to authorize Pfizer likewise for this specific age group because the safety profile and efficacy are looking very good. The results have been, right? Efficacy almost approaching 100% in regards to preventing COVID-19 infections for this particular age group. So Tony Fauci has said he expects the US within days from today to have an approval by FDA for vaccinating children in this age group. Now, why is this important as it relates to, again, herd immunity here in the US being critical for returning our workforce back to a sense of normalcy? If we look at our demographics here in the US, we know that children, when we're talking 18 and under, make up a significant proportion of our population, 26% to be exact, right? And so if we're considering reaching herd immunity of 80% of the entire US population having resistance to SARS-CoV-2 vis-a-vis vaccinations, we know that children, those 18 and under, will need to be a critical part of that effort, right? And so now we can see when we have the Pfizer vaccine approved in this age group, what the trend will look like for parents getting their children vaccinated. And we'll give glimpses as to some of the infrastructural parameters that will be in place for this age demographic, perhaps as a result of school mandates a little bit later in this presentation. So as we look at then daily new confirmed cases we want to remind ourselves of how the US is doing in terms of downward trend compared to the rest of the world. We're still far above the rest of the world in regard to 7-day rolling average for confirmed new COVID cases. So that suggests that we are not approaching a threshold at this point in time in which a return to normalcy is feasible. And if we look at the downward trend right now, we are definitely months away, right? Not just 1 to 2 months. We're talking 3 to 5 months likely away from a return to normalcy in regards to the social distancing and protection we've had in place all this time since the pandemic first began, okay? And so as we talk about additional causal examinations, we want to really focus in on the race to vaccinations and global herd immunity timeline, all right? Because again, SARS-CoV-2 variants are in play. We've seen them since day one. The S and the N strain we talked about in Wuhan, China, way back last year. We've seen the emergence of the UK, the South African, and the Brazilian variants emerge with specific characteristics that may help them evade immunity from a natural immunity perspective, right? And so that is why it is critical for vaccinations to be the primary way and pathway for us to ensure global herd immunity. So if we look at then the threat with some of the trends we've seen just this week and last week, right, emerge, we know that India is critical to a global herd immunity perspective. If we see what's happening in India right now, they are experiencing a second wave of COVID, spiking that began spiking about 7 weeks now, right? And they're continuing to climb. Their hospitals are overwhelmed, they're outstripped their resources, and they're having to import oxygen into the nation from countries, and US is contributing to that as well in terms of helping and supplying aid, right? And so when we look at what is going on in India and the potential threat for US return to normalcy, we know that the genomics of SARS-CoV-2 in India may be likely different than what we've seen anywhere else, all right? And about 3,600 genomic samples have been taken from January 2020 until April 21 in India. And as you examine the different genomics, we can see the different makeups here, the variants down in the key here. And the majority of the cases that are happening today fall into this other category. So what's likely in that other category, and there's more data pouring out to substantiate what's likely in that other category, which is the new India variant, B1.617, okay? And what we know to be true about this variant is that it's considered a double mutated variant in that S protein segment, right? That's critical for it to enter the human body. And those double mutations we've not seen until now in one particular variant, but we have seen the individual mutations in the UK variant and the South African variant. But now we're seeing both of those features in one particular strain, which may make it one, more communicable in regards to transmission, two, more deadly as the UK virus increased risk of death, as we saw multiple studies point to, and then three, evade immunity, natural immunity, as the South African variant has shown us to have properties of as well. Okay, and so this variant, as we've been prognosticating before, we have continued variants pop up globally. Now we're seeing it play out live in India, and it poses a threat to the US. How much of a threat, right? So let's look at that. India variant globally has been looked at, the B1.617 variant, and detected not just here in the US, but also in the UK, in Australia. And you can see the line of countries, 18 in total at this point, being shown that have this particular variant already in the population, right? And so as we talk about global herd immunity, this trend emphasizes the need for vaccines to be a critical part of getting not just the US back to normal, but getting everyone globally back to normal. And it lets us know that we are going to continue to import variants into the US. And in fact, obviously, you've heard most likely that we've shut down transportation from India into the US because of this variant and the threat that it represents, right? Obviously, we're not going, as new variants pop up, we're probably not likely to see a closing of the borders around around nations that are potentially threats from a variant standpoint. Obviously, that would be poor relations for us globally if that should occur en masse. But again, we're saying this not to be doomsdayers about what may play out globally, but only to suggest that we are far from a scenario of global herd immunity, which makes a reality of US herd immunity even more difficult if we're not pushing and going through a vaccination pathway. Okay. And again, this is all going back to the argument in the business case of why we should be looking at documenting who's vaccinated in our worker population so that we have the opportunity to return the workforce back to a sense of normalcy sooner than later, hopefully before the end of this year, if we bolster efforts through vaccination. So let's look at what WHO is saying about the India threat. We can see that it is not yet listed as one of the VOCs, the variants of concerns, as of April 19th. So we will likely see WHO come out with new representation of this variant on their list of VOCs because of what's occurring in India right now and the threat globally, again, to multiple nations. So if we summarize the threat and the trend from India, which will likely play out from other nations as well, right? The spike will prolong our journey towards herd immunity globally. The vaccination efforts in the US, right, are only a fraction of what's needed globally to get us to a herd immunity. And then the B.1.617 variant is already spread to other nations, is already here in the US, and may likely represent another opportunity for spikes in the US for COVID cases. Anecdotally, what are we seeing at work here in our data? In our day-to-day, we're seeing increasing trends of cases, right? Increasing calls, increasing quarantines. And so as we continue forward here in the next weeks to months, hopefully we see that trend reverse. But again, with these variants in play, it is likely to be something that continues in the wrong direction if we don't have increasing levels of vaccination. So when we're talking about the true undergirding of thought leadership, how can we think differently about our workforce in regards to keeping them safe and trying to return them to a sense of normalcy and experience a downward trend of protectionism, right? Or a winding down of some of the measures, right? Obviously, we all want that. How do we realistically achieve that in the months to come in 2021? And we believe that creating safe workplaces as well as public spaces through vaccination verification is feasible, right? It creates essentially, and this is a little bit of a thought experiment and some of the undergirding of what CDC is recommending in a way, is creating a hyperlocal herd immunity, right? And so here's the thought experiment real quick. If we are able to, actually, I want to play a video for you. Let's do that real quick, because this gives you an idea of what we're trying to achieve in partnership here at WorkCare. I haven't played too many videos for you guys on these. We're going to hopefully make it super simple here. There we go. Try it one more time here. And Karen, let me know if everyone can hear the audio. If you can't hear the audio, Karen, just let me know in my ear here. Can you hear that audio, Karen?
I'm not hearing the sound, no.
Okay, got it. Let me get the audio up here, guys. Just pause with me for a second.
Okay, now it's working.
Okay.
Ready to access life at full capacity? Introducing Traffic. Transformative recovery action for communities. We are transforming the way that communities handle contact tracing. We are driving economic and emotional recovery efforts. We are helping individuals and businesses take action in the new normal. Traffic services are completely free and easy to use for individuals wanting to get back to the places they love. Businesses and venues of all sizes are provided with actionable insights to open and resume full operations, with the safety and security of users at the core of our operation. Join us as we drive community and commerce back to full capacity. Learn more at traffic.org.
Excellent. So we share that to hopefully inspire you a bit to think differently about how we can create hyperlocal herd immunity, right? So the thought experiment plays out like this. In this scenario, this effort, Traffic, is a work care physician-led effort to help communities return back to normal as soon as possible, but safely, right? And so through vaccine verification, right, the classic way we do vaccine verification now, right? You get vaccinated, you have a record that you present to your doctor, we sign off on the documentation that you have been vaccinated on X and X day, appropriate to have immunity, right? And then you're able to attend school, as every child that attends public school has done for decades, right? Same thing with colleges, as we'll talk about a little bit later. So this effort, in a sense, creates a hyperlocal herd immunity. For example, a restaurateur that wants to fill back up to capacity, or an employer that wants to have a workplace without the necessity for masks and social distancing, right? Verifying enough individuals, 80% or more, who have been vaccinated allows you to limit the risk for transmissions of COVID-19, both in public and private spaces, right? And so again, the whole effort here is not to create a scenario in which you got to get vaccinated in order to access certain ideals of normalcy, but the whole notion is, how do we create safe spaces, get people back to normal, get our workforce back to normal as soon as possible, but doing so safely? And we believe vaccination tracking verification can be the way to get there, right? And then we want to talk about the lawfulness of vaccine verification. And the simple answer is, let's follow what's happening with universities, with schools, right? We know that there's still an ongoing debate, as we talked about last month, in regards to how the US is legally looking at an FDA EUA, emergency use authorization, right, compared to a full FDA approval of these vaccines. And as it stands right now, we don't have an official ruling on the comparison of the two in regards to, are they the same, or are they different from a legal statutory standpoint? But we still will look forward to the answer to this and continue to talk with the professor we mentioned, Professor Santos Rutzman, from last week. But what we are seeing in the trend of universities is a play out of new universities signing up and mandating vaccinations for the fall semesters, right? And so what we anticipate is an opportunity, so as the universities have taken efforts to get their populations back safely and hopefully return to a sense of normalcy sooner than later, then we can look towards perhaps employers following a similar trend. And this is just a snippet, not a complete list. We have the link here if you want to follow it, of looking at all the universities that have signed up state by state and said you have to have a vaccine. Now, some of them will continue to hinge on the FDA full approval, right? Unless government says EUA is equivalent to full approval from a legal standpoint, right? So we'll look to see how many universities continue to sign up. And again, for more a complete list here, you can follow the link that we present. In this case, the University of New England just recently signed up, as well as a couple other universities. So we'll continue to follow this trend, but we believe it to be an important trend in regards to not just the macro trend that we'll likely see with employers, but also any trends that will play out in public venues as well, right? And so as we talk about the messaging now to our workforce, the undergirding of the simple. This is nothing new, right? We look at COVID-19 obviously as a pandemic that none of us living have gone through before, except for SARS-CoV-1, which was not as impactful, particularly to the US, right? And MERS. But again, at this level globally, we think about COVID-19 being a substantially new perspective on health and wellness in the workplace and beyond. But what's not novel and what's not new is the requirement for verification. And that's the messaging we want to share. We want you to share with your employees that, for example, yellow card verification has been required, and it's been required for decades now. It was authorized by the WHO to standardize how we travel and prevent communication of illness from one country to another, right? And there are multiple platforms out there to help you verify your yellow card. And that's bread and butter for occupational medicine outfits like our own at WorkCare, right? And so these efforts have been and should be familiar to your workforce. And we want to emphasize these requirements in place for travel and for other normal operations for us nationally, right? And that messaging will hopefully play out in regards to how this is a similar effort with COVID-19, right? And if we look at the overall continuing trend of passports, we know that it's not just WorkCare, right? Thinking about COVID passports, you've heard about COVID passports, I'm sure, in the news, but there are concerted efforts to make sure that safety in regards to data safety or data privacy is paramount with regard to COVID passports. And it's likely to be a step that we see globally. And WHO initially came out against passports. Why? Because logistically rolling something out for COVID at this point in time would be too onerous of a task to coordinate from nation to nation and then provide the means to do so for nations, right? But we believe that this trend will change. The opinion of WHO will evolve into more of a, if we're going to reach global herd immunity, then there will be a requirement for some level of vaccine passport, and certainly in intra-country or inter-country passports is going to play out first, right? So passports that are used in the US, used in Singapore, used internally in a nation will likely come to fruition before there's an international passport that's globally used. However, there is global efforts, Microsoft, Salesforce, Oracle, as well as Cerner and Epic, which represent 65% of all health medical records in the US, have joined an effort to create safe passports for COVID-19, right? And they're using security like QR codes to keep it simple, but to de-identify records But the more important thing is the digital confirmation is shared freely in an open source kind of way, if you would, amongst members of their consortium. And WorkCare several weeks ago became members, general members of this consortium, so that we can participate in efforts, hopefully, to get our workforce, our general population back to normal sooner but safely, right? And so if we can think about this opportunity a little different in regards to tracking. So anecdotally, our clients at WorkCare have not been tracking vaccinations end to end, right? Even when there's efforts to provide vaccines to the workforce, there's not been a tremendous effort to track who has and who has not been vaccinated, all right? Now, obviously, we understand the legal ramifications around the privacy issue, but if we are talking about a classic model that we present at WorkCare of a physician group holding records for and on behalf of our covered entity and our covered individuals, meaning the workers, then that paradigm doesn't change from the traditional model in which your clinicians play a role in verifying vaccines, right? And through that vehicle, through our concerted efforts, we can then track and maintain a population trend towards that hyperlocal herd immunity for that workforce. And the risk reduction, again, is tremendous. And that's why we have the CDC saying, hey, it's safe if you are in your home or have a small gathering and everyone has been vaccinated, or the majority of people have been vaccinated. Why? Because, again, it's a hyperlocal herd immunity, and risk reduction is tremendous in regards to COVID transmission. So that's what we want you to think about today. We're going to wrap it up. I think we're at about 42 minutes here. So we want to give time for questions. So let's jump into it. Thank you so much.
Hey, thanks, Dr. Harris. I miss our weekly webinars, so it's so great to hear from you, even though we're just doing it once a month now. So we have some really great questions. Relative to your concluding remarks, someone wants to know about the potential for a HIPAA violation if you ask employees for proof of vaccination. What would happen if the person is vaccinated but refuses to disclose that they're vaccinated?
Sure. So if someone, and again, great question around HIPAA, right? So if someone volunteers information, so the first point, someone volunteers health information, there's no risk of HIPAA violation there in regards to them sharing with you as the employer. Obviously, no violation if they share with us as the clinician, playing a party to the effort to track vaccines in this case, right? Now, a HIPAA violation could occur if that knowledge, once shared, then is shared from the employer side, or frankly, through a covered entity like ourselves, with a third party that is not a part of that overall, what's called BAA, Business Associate Agreement, right? That could be a HIPAA violation, but the violation risk is nil when we're talking the individual worker communicating their status to both the employer as well as the clinician. Now, if they refuse, they refuse. This is still a voluntary effort, right? Now, if we go back to last month and the employer says, look, we are going to require vaccine verification, there's still legal support for that. And we know that the precedent has been referenced by CDC, by EEOC, et cetera, right? So there's legal ramifications under the general duty clause of OSHA and a requirement of employers to keep employees safe to require vaccines, and refusal to do so. Obviously, we'll look at litigation as it may surface under that scenario. I haven't seen any litigation yet around that, unique to COVID-19, but it's likely to not prevail because we know there's a tremendous amount of already communicated opinion legally for a employer to require, which is why we see universities requiring for students and faculty to attend in person for the fall and into 2022.
Okay, so we've got a lot more questions related to this same topic. One comment about concern. Is there a concern with employees being singled out if they chose not to be vaccinated or cannot be vaccinated for health reasons that contraindicate them being vaccinated?
So
how can we deal with those concerns?
Sure. So the beautiful part of the partnership that we've been able to foster with our clients' employers is that other employees will never know, right? Because unless it's shared by the individual themselves, if you have an underlying medical condition that prevents you from being vaccinated, your covered HR personnel and the clinicians on our side would be the only party, would be the only ones a party to that information, right? And so singling out in terms of, it being known that John Doe or Sally didn't get vaccinated should not play out in the workplace. And that's a very important point that we want to emphasize. It is incumbent upon the employer to protect the status of an individual from public knowledge, right? But again, it is within the purview of the employer to know in a limited fashion those who are covered under the HR purview, and as well as the clinicians involved, and that's information that stays there.
Okay, two questions that both refer to OSHA. The first one starts with a comment. My company considered requiring employees to be vaccinated. We have decided, at least for the time being, not to do so. One of the considerations is that OSHA has taken the position that if a company mandates employees be vaccinated, then vaccine reactions that meet OSHA's record-keeping criteria must be recorded. Can you comment on the risk of recordables due to vaccination?
Sure, that is unavoidable, right? And it's a byproduct of the requirement, and it's straightforward that if required vaccines, which is legally enforceable at this point in time, is part of the employer's approach and a requirement for employment, then by reason of causality, if a reaction happens for an individual who has received the vaccine only because they are complying with the mandate for employment, and that reaction is substantial enough, then yes, it becomes an OSHA recordable because without the workplace intervention or the workplace scenario, that individual would have not likely experienced a reaction to COVID-19 vaccination. So that's a straightforward one, unavoidable, clearly. But again, if we look at the risk of reaction substantial to warrant an OSHA recordable, again, it's few and far between, right? We're talking less than 1%. So I think the risks still do not outweigh the benefit of trying to get your workforce back to a sense of normalcy. And as we move through 2021, that's going to become ever more important as COVID fatigue, we've talked about months before, continues to mount. The impact from mental health continues to mount, and it's a resultant of, again, the workplace not being in a state of normalcy throughout the pandemic.
Okay, and another person asking about OSHA. Is there any indication of when OSHA may issue an emergency temporary standard on COVID, and any idea what it may require? So I've been following that, and you can elaborate on this, Dr. Harris, but I know it's been submitted for consideration, and you can learn about it on the OSHA website. It's been requested by the Biden administration, is in process right now.
Yep, that's 100% true, and we'll see what plays out. Previous administration didn't go there, right? For a broad OSHA emergency kind of stance, but we'll see what happens with the Biden administration and whether or not it promulgates. But I believe anecdotally that having such support, and we've seen and heard anecdotally employers voice support for an OSHA emergency that helps them with their the fragmentation they've seen so far with different stances the states have taken with the state OSHA.
Okay. For those of you who are used to our usual format, I just want to remind you we have a full hour. So we'll be taking questions till we run out of time. So for those of you who can hang in there, we'll be on for 15 more minutes or so. Here's a question about controls. Can you have controls that are applicable to unvaccinated people, like social distancing? I'm presuming this means controls in the workplace that would apply to an unvaccinated population versus a vaccinated population.
Indeed. So in terms of controls, if we look at, and we spoke to this some time ago, looking at the hierarchy of controls, right, from an industrial hygiene standpoint, there are some facts and trends of COVID-19 controls that have been put in place that will likely persist beyond COVID. And we believe those controls, such as barriers, physical barriers between workers, particularly in those manufacturing and food preparation industries where workers are adjacent to one another and it's unavoidable to social distance in regards to 6 feet or more, right? So those physical barriers have been helpful and effective for helping prevent exposure and transmission, and will likely persist beyond COVID because it doesn't encumber the individual workers to the point of hurting productivity. And again, protective factor for not just COVID, but also cold and flu is an advantage as well. So yes, controls will likely persist and be a part of our new normal, such as also we've seen with employers putting in place IR cameras, right? Infrared thermography, so that from now until in perpetuity, every worker who walks through the doors will have a temperature screen. And again, will that be helpful during cold and flu season? Perhaps. And we want to elevate and continue to have a high standard for workplace transmission, prevention of workplace transmission, not just of COVID, but others. From a standardization that separates vaccinated from unvaccinated or immune individuals from non-immune individuals regarding COVID-19, we're not likely to see any bifurcation of any standards there, only because that type of bifurcation would not be helpful, we believe, from a overall enterprise approach to safety. And it obviously won't be supported state by state either, as you've seen states such as Florida, Governor DeSantis come out against COVID passports for that very reason. He didn't want to create the have and have nots. If you're a Dr. Seuss fan, the Sneetches with stars on their bellies and the ones without. So I agree that we can't get that far into singling those populations out, but we can put in place broad protective measures that help everyone.
Okay, great, thanks. Here's a question about return to work. When making return to work decisions, how should an employer view employees who have only received one of the 2 doses if they're getting Pfizer or Moderna?
Sure. So that's a case-by-case determination that should be taken up with your clinical partner, right? Whether it be us or otherwise, because there needs to be a deeper dive into the administration of the vaccine in that case, right? And we know that if everything went well in regards to efficacy for that individual, after 1 dose of Pfizer or Moderna, their likelihood of being immune and having resistance is about 80%, right? But there have been anecdotal scenarios in which I've been a party to as a clinician, in which someone received their first dose and it was a dose that was injected subcutaneously, right? And that meant likely the subcutaneous dose was not properly metabolized, if you would, by the immune system and did not present a seroconversion, meaning that the individual didn't have a systemic response appropriate to develop immunity because of inappropriate or inappropriate placement of the vaccine itself, right? And so it is critical to have a case-by-case determination as to whether or not individuals can be placed in a bucket of, yes, likely to have 80% immunity after one dose, or because of the circumstance, may not be in that scenario.
Okay, we have a couple questions about vaccine effects. One is related to short-term, and one is related more to long-term and what the latest research is. So I'll read you the question. Now that more and more vaccinations are occurring, has there been any additional insight on negative reactions to the vaccines? Is there any difference between manufacturers or the first and second dose? And then another person wants to know if there's more information on long-term effects of vaccines.
Sure. So in terms of the response from vaccines, adverse reactions, we're not seeing higher numbers than, we're actually seeing lower numbers than what we saw in phase 3 clinical studies, both for Pfizer and for Moderna, okay? And so that's obviously really good information, as well as really hopefully motivating to those who have not been vaccinated in your populations. Likewise, efficacy is even a little higher than in phase 3 clinical studies as well, again, supporting the notion that vaccines are safe and effective. In regards to long-term effects from these vaccines, at most we're starting to get data back on those individuals who participated in the phase 1 clinical studies of these vaccines, particularly the Pfizer and Moderna, who are a year out almost from their initial vaccination. And these are the individuals that participated in large part in the booster study as well for these vaccines. And so we have not seen a dramatic change in safety profile so far, and efficacy is still pending in terms of longevity of immunity. But as far as we understand it from the manufacturers, it's likely the booster is going to be needed at a minimum annual basis.
Okay, we have so many great questions. Now I'm thinking we're not going to get through all of them, but just want to remind you all that we do answer them all and post them on our website. So if we run out of time, we'll take care of it after the fact. Should an employer who offers testing stop testing if their employees are becoming vaccinated?
Sure. So the answer to that is it depends, right? And so the approach that we want you to take is, one, what is the proportion of individuals in your workforce population that have been vaccinated? Is it a hyperlocal herd immunity, right? 80% or more individuals. And even in that scenario, right, you have to still look at what is the community transmission rate for that, in which that workforce lives. Because if community transmission rates are still substantial, testing will still need to be a part of the paradigm for that employer, right? Now, if both are satisfied, you have higher than 80% or higher in the population vaccinated, and local community transmission is relatively low. Again, don't nail me down on a specific number, because then I'd be out of line with CDC, who has not put out a number as well. But we can individually look at local populations with you as a partner. Then it may be feasible for you to not offer testing, but still offer screening, right? And that's what we would, that's how we would position that scenario, in which screening for symptoms would still happen, because again, is that something that may persist? Yes, in some shape or form, right? Not just for COVID, but for cold and flu season. When we talk about testing for cold and flu season, we still haven't seen any definitive trend that we're going to have higher testing during that period of time than what we've seen with COVID.
Okay, a couple more questions. What evidence do we have that vaccine immunity is longer and or better than natural immunity?
Sure. So we know that vaccination causes a 40 times increase in immune response in terms of creating immunity to SARS-CoV-2 than native immunity, meaning you've contracted and recovered from COVID-19. And that's looking at the serology, looking at the antibodies that are formed. And so it's that potent response that offers a increased resistance, not just to the native wild type SARS-CoV-2, but also the varietals that we're seeing in terms of variants to SARS-CoV-2. And that's critical, right? And so that's why we're saying vaccination is the best pathway, because just like in Munas, Brazil, the data that we presented last month, I believe it was, we saw the populace there from a serologic standpoint, estimated 76% of individuals had contracted and recovered from SARS-CoV-2, right? COVID-19, and that was in the fall of last year. Social distancing was relaxed and only to be put back in place December, January, when they experienced spikes again, more dramatic than before. In that same supposed immune, right, herd immunity almost levels of population because of variants affecting those who had been previously affected from SARS-CoV-2. So we know vaccinations are key to prevent those type of scenarios.
Okay, two more questions. Have you heard of any further studies on booster shots for immunization?
Beyond what Pfizer has come out and said, no. So we're still waiting to see final recommendations on when boosters will be required timing wise, and efficaciousness from a longevity standpoint is still pending as well. So hopefully we'll, by next month, have an update there and be able to give more insight as to how do we begin to get those who have been successfully vaccinated in 3 to 4 months time, because it's been 2 months now of essential workforce being vaccinated at a minimum, right? How do we start to get them booster shots? How do we coordinate that? And how do we make it something that is not too disruptive to the workforce, as obviously the logistics of all the vaccination offerings have been in many scenarios.
Okay, and the last question is related to vaccinating children. Can you please explain the rationale behind vaccinating children? I believe that generally speaking, with outliers, of course, they're not in the high-risk group and not likely to become ill if infected. So if those are in the risk group are vaccinated, it should not matter if a child is exposed, they are exposed to is a carrier.
Sure. So the key to children is that they represent 26% of the U.S. population, right? If they were a fraction lower than that, right, 10%, 15%, then we could reach herd immunity without the kids, right? But because children they're susceptible, right? They're not immune to SARS-CoV-2. They're susceptible, meaning they can contract and they can transmit SARS-CoV-2, and that's critical, right? We talked about the R0 number, the reproductive rate of SARS-CoV-2, which is roughly 1.8 to 2.5, up to 5 in some cities, right, in the U.S. So that means children are a part of that picture. And so unless we get, even if we got every adult in the U.S. vaccinated and immune to SARS-CoV-2, we still wouldn't reach a level of herd immunity of that 80%, because children make up 26%. So the risk of transmission in the general population, right, in theory, would still be present, albeit, again, that scenario in which every adult was vaccinated and immune, yes, would agree with you that the risk would be still low for transmission. Are we likely to ever get to every adult in the U.S. being vaccinated? Obviously, the answer to that is no, right? We have enough likely in the population that can't get vaccinated for underlying medical conditions and or religious beliefs to put us far below the level necessary for adults, not to mention those who are not leaning towards getting the vaccine. That is why vaccinating children are critical to us reaching the return to normalcy because of that herd immunity number.
Okay, unfortunately, we're out of time. We still have questions. Thank you all so much for submitting your questions, and we will get Dr. Harris to answer those that we couldn't get to today. And those of you who had specific questions about traffic, we'll elaborate on that as well, because this is the first time you've heard about it, most likely. So we'll get back to you on that. Thank you so much, Dr. Harris. We'll look forward to seeing you back next month. Thank you all for joining us. Take care. Be safe.
Thanks, everyone. Yes, be safe. And as always, God bless.